about it, we make sure we ask about that and talk about ways to integrate the new perceptions and insights into their lives. And we really talk a lot about the fact that this will continue to unfold and that it often comes in waves, and thoughts and emotions may come in waves for days or weeks or the rest of their lives. And that what was I going to say? Well, sometimes the waves, it continues to unfold in waves, and sometimes the waves are really easy, you know, wonderful waves of gratitude and new insights and all that. That's often part of it. But sometimes the waves are more difficult, of anxiety or other painful feelings coming up, and just to let them know to anticipate that, encourage them to communicate with us about it, and work with whatever comes.
You know, sometimes people will realize that they are at a job that they hate or in a marriage that isn't working. So you also are reminding them that you don't want them to change things the next day or the next week. So some of the integration can be around that to take your time and will help you process this newfound realization.
Yeah, one person the first day, a woman called us the day before her follow-up session the next week, and she said, "I can't make it tomorrow. I've got an appointment with a divorce attorney." And we said, you know, we really encourage you to hold off on the divorce attorney and come talk to us first. And she did, and she actually ultimately got divorced after the study, but because she had realized that this wasn't a good marriage for her. You know, she had valuable insights about that, but she was a wee bit impulsive about acting on them, and so it worked out much better for her to spend some months processing this with us and with her husband. And the reason we have the physical space and boundaries again is that sometimes, as we said, we do body work in follow-up sessions. And yeah.
Why did you discourage people from changing things rapidly? Maybe it was something they should have done years and years ago.
Well, true, there could be situations when they should change it rapidly, like if it was abusive at the moment. But in this situation, it seemed like she hadn't had time to fully process and integrate what she wanted to do, and that she had mixed feelings about it, and that she hadn't really processed with her husband. So it is kind of a bias that we think it's better to go slowly when you're in the middle of this process and let the process unfold more fully before you actually make big changes.
It's also similar to in the session when we said be with the feeling of wanting to leave, to take it inside, take the feelings and work with them and process it before you act on the impulse. So it's a chance while they're in the study to do that, to do the work.
So in this, you know, the first one's pretty obvious. If there's something adverse has happened, we check that out carefully to make sure it's okay for them to have another session. We never had a time when we thought it wasn't, but it's possible. We really re-emphasize our commitment to support them through this whole process, not just the day of the session, you know. And we schedule phone contact every day for a week, and then we invite them to call us anytime. We have our cell phone 24 hours a day. They know they can always get us. That's our commitment while they're doing this. And, you know, we talk to them about the fact they're going to be physically tired, most likely, and they've done a lot of emotional work, so to take it as easy as they can, rest and relax as much as they can, be easy on themselves. And then we talk about activities that may support ongoing integration, like journaling, collage, other creative expressions, meditation or yoga, reading, whatever, you know, works for that person. But really talk to them about it's not just the session, it's making space and having a practice in your life to really allow this to continue to unfold in a useful way and to be integrated. Shall we take a break? Yeah. Yeah, okay, it's 3:15. Let's take a 15-minute break, and then we'll come back. We'll finish these last few of the integration ones, and then we'll do a demo, whatever. Reading of the script of the session. So you've got the rest of this integration session part on your handouts, and if we have time to come back to it, great. I just wanted to touch on one part of it, which is suicidality and suicidal thoughts. This is very common in PTSD patients. As I said, the VA says that one veteran is committing suicide every 80 minutes right now. So we definitely have veterans in the study who have been suicidal and who are suicidal at times, and we've chosen not to exclude them, because if it's a huge part of the problem, we ought to be able to include them, so we do. We really are hopeful that MDMA can and does help with this, but it may, just like anything else that may get stirred up, people can get more suicidal thoughts. We haven't seen it in an MDMA session, but we've seen it after an MDMA session. In fact, we've had to go back sometimes in the middle of the night to sit with someone who's having suicidal thoughts come up. So I just want to bring that to your attention, and it's just, it's part of the integration process to help people work with that and move through. They need safety and support to do that. So actually the FDA now requires every psychiatric drug study to include the Columbia Suicide Severity Rating Scale, and we use that now. It's, kind of a useful thing, but it certainly brings our attention to checking on where people are with that. So that's important. So let me turn this off. Well, are you up for this? We have a transcript from a session, and even though we've compressed it and taken out a lot of the pauses, it still lasts about 45 minutes. Are you up for that? Yeah. Okay, good. Okay, so a couple things about this. I think there's some people here that weren't here earlier. The video has to be turned off now, and because we have permission from this veteran to do this, but not to have it recorded, which we think is appropriate. We don't want it showing up on the internet anywhere. But he either had 1 or 4 more sessions. This was his second session, and he did have at least 1 more session. Sorry to be evasive, but it's important not to broadcast the unblinding stuff.
Do you typically notice that whatever the initial PTS symptom is, that there's usually a foundation to it that goes further back in their childhood, like what he described on the farm, for example? There was a foundation perhaps in his family that kind of led to the development of the PTSD, and that you went back and kind of worked on that as part of the treatment?
Usually, I would say always there are connections to childhood and processing of difficult childhood experiences of some kind. Very often they do seem to be kind of something that predisposed the person to PTSD. And we work with it all, and it's like their spontaneous process determines when and how much that comes up, but it always does in one way or another, yeah.
After MDMA-assisted sessions, and in particular MDMA-assisted sessions like that one. Is it difficult to go back to non-MDMA-assisted therapy sessions? Can it be frustrating at times to not have people be as open?
In a way, yeah. I mean, I don't really experience a lot of difficulty about that, but there's some truth to that. Yeah, the MDMA does make it easier in many ways. Although, as you can see, it doesn't keep you from having these kinds of challenges. And I do love doing sessions this way.
And thinking back to people that we worked with breath work, people can get to the same places with other therapy, but it takes a lot longer. And the amount of therapy that is done in one session is a lot, and it's also a lot for people to take in as well and to work with. So they have a month in between experimental sessions, and maybe it'd be better if there was a longer time, but that's how we have the protocol set up, and because there's a lot that comes up.
George Greer said there's nothing you can do with MDMA that you can't do without MDMA. You just might not get to it in this lifetime.
Watching the MDMA sessions, it's really frustrating for me to treat people with trauma, which is very difficult, and not have this medicine. It does take a long time. It's really difficult.
It seems like there's an existential piece to several of the things we've looked at. Like if you're in war and you kill people, then you did kill people. And if you were, even as a kid, if you were sexually molested and there was pleasure, then there was pleasure. And it seems like I'm really interested in the integration process of bringing that into your life and somehow coming to grips with that. And obviously, if you've been working with MDMA with lots of people, you've seen that. I'm curious what do you think about that? How does that work? How do people do that?
I don't know, but I agree with what you're saying. And sometimes with sexual trauma, the hardest part is accepting that it felt pleasure as well as it was horrible. I'm not sure how to answer that, although what we've seen is the MDMA tends to help people bring a lot more self-acceptance to that. Part of it is also, feeling that the therapists are non-judgmental and they're accepting it helps to allow that. But I think the MDMA often helps people pass, maybe those are some of the blocks we're talking about, the obstacles to successful treatment, that they just couldn't accept that they did that. And so I don't know how, but the MDMA seems to facilitate that process.
And I think the thing about the sexual abuse is, you can normalize that and say that part of it is the body reacts to the pleasure, and people like to have you tell them stories of other people's experiences to help with that. But one thing about the rage and the killing, Michael had a breathwork experience where he also felt what it was like to have adrenaline and rage and wanted to lob off people's heads. And he shared that with the same vet when we were doing some body work. And it was just magical that, they could be on the same wavelength about how that's just, it's part of us and part of the adrenaline. That helped. But I think partly the MDMA lets them hold both of those polarities.
There's just really debilitating shame that's so isolating when you're working with patients or survivors of sexual abuse, and the MDMA allows the patient to access those memories and to talk about them without the shame.
Is that if you want to get into this, but the VA to take care of the PTSD GIs, the soldiers, is that going to be kind of, what you're saying, it's a fast way to do that? Is that going to be the politics of this in the end when this becomes accepted? Is this the fastest, cheapest way to take care of our vets? Is that something? I'm just interested in the politics of this whole thing. Is how is this going to move to the next stage where you can use this on a regular basis for veterans and for people who need it?
Well, that's a really good question, and you know, the politics is complicated. I think even though it's more expensive up front, I think it probably is the fastest and least expensive way to treat people compared to what it costs for these chronic, the cost for chronic PTSD. You know, so far we're been for a number of years now intermittently trying to, you know, to collaborate, find ways to communicate and collaborate with the VA and the Department of Defense. And so far the VA, you know, we've had several psychiatrists and psychologists at VAs that wanted to do the research, and they've gotten to a certain point and been blocked by the administration, and we've basically been told they need a memo from the Secretary of the VA in Washington in order to do anything this controversial. So there's a lot of inertia. But we're hopeful that especially if the vet study continues to go well, maybe that'll help, but I don't know. I think eventually it'd be really great to get them involved. You know, we've said, if you want to do the studies yourself, we'll give you all the protocols, we'll help you, we'll train people. You know, we'd love to have them involved because they can make big studies happen fast with their funding. But it's not happening for a while, I don't think.
I just wanted to congratulate and really applaud this work, because if this is where psyche care is evolving to, then really, and watching and observing such amazing breakthroughs happening in such a short time, there's beautiful hope for, you know, collective human psyche healing and on the individual level as well. So thank you for your work.
Thank you very much. I'm really touched by that, and we're constantly touched by being able to, the privilege of being able to be present and support this kind of deep work. These people that do this are so courageous, you know. It's scary for them, and they do it. So thank you.
Back to the question of ordinary psychotherapy after one of these instances. I know a couple of circumstances where patients have switched to 3-hour sessions instead of 1-hour sessions and do them less frequency, in part because some of the anchoring is to the time frame. There's the set and the setting, but the amount of time that they actually take to settle down into the place where they can go there, that's part of the experience. And I wondered if you have recommended that to anybody. The two circumstances I know of, what folks say is about 1.5 hours is ordinary therapy, and the second 1.5 hours of a 3-hour session is just like the journey that they were taking with the MDMA.
Yeah, that's an interesting point. Usually it hasn't been feasible for people to do that. You know, Annie and I have worked sometimes with people for longer sessions, and I think that there's a lot to what you're saying. It's just hard for most people to be able to do that.
Thanks for a great workshop and the role play. I enjoyed it. I'm wondering, as a therapist, if you've ever had the desire to take MDMA yourself, and if you think that would be helpful in the therapy.
You mean in the therapy with the person?
As a therapist, yeah.
No, I never have been. I don't think it, you know, maybe it could be helpful, but I'm not drawn to the idea at all. I think it's not necessary, and it's actually much better for us to not be in that state. So I'm sure there could be some valid use that way, but it doesn't appeal to me. I think it's so powerful, and without doing that, and also I think it might be harder to really keep it being the other person's process, I would say.
I'd like to make a comment about that. I am very much in favor of the indigenous model where the healer takes it too. The most powerful experience I had in my life was after my husband committed suicide, and I went to a peyote meeting. And it was very difficult for me, and it was very difficult for everybody in the teepee. It ended up all revolving around me, even though it wasn't initially for me. And they told me I wasn't responding, and they were having a hard time. It was hard for them to bring me back. And they said that it helped them all in the long run. So they do it together, and definitely the shaman takes it too. And I think being emotionally on that wavelength, the same wavelength with the patient, takes you to heights that are way beyond the conscious state.
Yeah, I'm sure that's true, and I have great respect for the indigenous cultures and their models, and I have experienced those myself. It's just in this setting, one thing we're doing with this research is trying to make this available to a much wider range of people in this culture. So that's part of the reason I feel this way for what we're doing. I'm not against what you're talking about at all. But right now, some people can get access to these therapy with these substances if they have the resources and inclination to do so. But most people can't. And I think to do it in a way that's more accessible to more people is part of our goal. Also, I don't see the FDA going for that idea either. So partly it's pragmatic that obviously we can't do that. But having said that, I don't feel that it's a problem that we can't do that personally. Although I certainly honor what you're talking about.
I think you're doing great work, and it's really amazing what you're doing. It's just amazing. So I'm really very touched by your work too. When you mention our culture, I feel that shamanism is deeply in our culture. It is our culture. It was burned out and destroyed by the Catholic Church, by all kinds of different forces in our society. But getting back to the shamanic model is what so many people are seeking, and I think we're simply getting back to our own roots when we go back to the shamanic model, rather than, I understand you are within the boundaries of FDA at this point, but I think it's good to look past that. And sometimes there's a guy in Hawaii who has these marijuana, it's like religious use is what he claims, and he gives out cards, and everybody just totally gets away with everything with these little cards that he gives out. He has a health license number. So I think legalizing it from that perspective, to say we have the right to communicate with the divine force the way we choose to, and FDA has nothing to do with it, I think might be a very powerful model too.
Well, I hate to use this expression, but maybe it's kind of like 1,000 points of light. There are different ways to have impacts and to approach it, and I respect that there are different people doing it in different ways, but we're definitely doing it within the FDA model because we think that is a way to bring this into the culture and make it available to more people. That's our way. It's not the only way.
There's a slide you didn't get to yet on further training. Would you be able to speak a little bit about what those plans are for the training program?
Yeah. Well, one thing we say in there is that we think holotropic breathwork training is one of the most useful ways to have experience with this kind of approach, so we really recommend that to anybody who's interested, even part of the training. In terms of what we're doing, it's, we have two things. We have a 5-day training program in which we go over a lot of this material, but we also watch a lot of videos from the sessions and have a lot of discussion about those. And then if people have finished that training and they are going to work in research and they want to have their own MDMA experience, then we have that other, it's actually a study, but it's limited to people who have been through the training and are therapists to have their own MDMA experience with us in the same futon there, to experience it under the same kinds of conditions. So that's kind of our model that we're developing, mainly moving toward when we can do phase 3 trials, which is going to be several years from now. So right now we don't have the training program going on in any continuous way. We've just kind of implemented it intermittently for these phase 2 trials that are going on right now. So it's a little frustrating for everybody because we're really happy that many people are involved and are wanting to be involved, and MAPS has a application form that people can fill out to express their, kind of get in the system for applying to work in studies in the future. And then the idea would be to have those people go through the training in order to work in phase 3 trials. But we don't want to train a lot of people now in preparation for that and then have a few years go by and find that they've moved or lost interest or that kind of thing. So that's sort of where we stand with it. We're not really in a position to do continuous training yet.
What are your requirements for the people that would be entering into that program?
Well, at the moment, they need to have training as a therapist or be in a program leading to licensure for a therapist, to be a therapist. I think that's those are the only ones I can think of at the moment. But if you contact MAPS, we're actually not handling that part of it with the applications and stuff, although we are involved in some way. But you can contact them, and we're delighted to have anybody that's interested do the application, and also with the kind of forewarning that it might be kind of frustrating because nothing's going to happen for a while.
Yes, Doctor, regarding the war-induced PTSD, where it does have its roots in childhood developmental issues, and since war-induced PTSD has a lot of its roots in the cases of early childhood developmental issues, has the MDMA experiments had any proof in recovering repressed memories in those cases?
We have not had any recovery of repressed memories. Nobody's remembered something that they weren't aware of. We have had people get more details about it and more clarity about it, but nothing new has come up in any of the sessions so far. Yeah, Ingrid.
The Danish woman I talked about this morning did have a memory of abuse that happened in her infancy that she'd not been able to access through other therapy or through a lot of breathwork groups. This was abuse that happened when she was an infant and under the age of 2, so she got those memories.
I'm not surprised at all that it could happen. We just haven't seen it. But, our numbers are not that great yet.
I know you probably don't have an answer to this, but Is the hope eventually out of this study that MDMA would be a prescription medicine that would only be prescribed by a medical doctor, or would it or could it be prescribed by some other mental health professional?
I think the way the system works now, it would have to be a medical doctor. I think if there were ways for that to change, I think that would be okay, as long as there was somebody, available for being responsible for the possible medical complications. But basically, yes, it would have to be prescribed by a medical doctor, but the therapy wouldn't have to be done by a medical doctor. So, what we picture as a possible model that would probably work with the FDA and would make sense to us is that it couldn't be you couldn't just write a prescription for people to go get it. It would have to be administered under, given to people in specialized clinics that were set up for providing the right kind of support for the session. Sort of like a methadone clinic is a model like that. Any doctor can't write a prescription of methadone. You have to have some special training in a licensed clinic. So I think that makes some sense as a way to do it. Then, other therapists could be involved. It could be that the medical doctor would just, administer the MDMA and be available if needed, and other mental health people could actually do the therapy.
Thank you.
I haven't heard you address this question, and I'm really eager to ask it. How has it been working with these two different populations? A few words, like the differences between working with the first phase 2 study and the second phase 2 study.
Yeah, well, it's challenging working with vets. They're trained not to talk and not to feel. They also, Michael mentioned the suicidality issues. There are a lot of things that we don't know about what happened over there. And everyone has done a good job of keeping us unaware of how we're a part of that. There's a lot of information and terminology that we don't know. It's a learning process. We've tried to read as much as we could to kind of understand some of the issues and where they're coming from. But, in other ways, they may have like a way of being able to wrap things up because of what they've been trained to do as Marines. They are trained to suck it up. So in some ways, maybe it's easier at times because they're so capable.
So it's almost 5:05. I think it's time to stop. We'd be happy to stay up here a little while if other people have questions, but I really appreciate you all hanging in there all day with us and all the good discussion. It's really enjoyed it. Thank you. Who wants to say one thing?
Just thanks for everyone showing so much respect for the gravity of how much people with PTSD are suffering, and at the same time, be mindful. Talking about trauma can be traumatizing, so take a deep breath and be aware of your body and aware of that you're not taking things with you.
Thanks. It's, I'm not sure how much this is a difference, but we're not trying to move anyone towards something more positive, basically. I mean, in the meta picture, yes, definitely, that's all of our intention. But we're trying to help people as much as possible fully experience and express whatever is happening, not to try to change it, and to let it evolve in the way it needs to. It's kind of a different principle. I mean, and one thing is we've got 8 or 10 hours with people. We don't have to get them back out the door in an hour and a half. So, I mean, I think that kind of work could be useful because it's obviously not absolute. Sometimes we do help people kind of settle and connect, but we don't do it exactly that way.
Yeah, and we're trying to help people be with whatever's coming in a different way than avoiding or shutting down or escaping out of their body. So as much as they can do that, and that's what and then we'll support them. We might put our arm around them, or we might sit side by side. And we'll also let them avoid, if they're noticing that they need to avoid the subject, we'll let them talk about things they want to talk about that are fun. A lot of times their animals will come up, talking about their cats or their dogs.
You know, that's, to me, that picture we showed about the container and then the individual variation among therapists, you know, if you're trained and experienced with that method, I'm sure there's a beautiful way you could weave that in, you know, as your own element to bring to it, too.
Yeah, so before we switch the slide, we had the question about what time do they take the medicine? So people come at 9:30, and a.m. we do a drug screening and urine pregnancy test for the women. And then we spend the next half hour doing the preliminary blood pressure and pulse and temperature and talking to them about what their night was like and any other concerns they're having or questions. And then they take the medicine at 10.
So do you collect the information of how much? So do you collect the information of how much sleep they got? Because if you're starting at 9:30, then you're probably at least half the folks you're dealing with have gotten less than 6 hours of sleep.
We don't formally collect that information. We always ask them to write down what they say about it, but we haven't tracked that formally. We also ask them, do they remember not to eat breakfast, because they have to not eat food after midnight. But no, that's an interesting fact. Usually people have gotten even less than 6 hours sleep because they're usually very anxious about what's going to happen, and they have sleep disturbance anyway with PTSD. A lot of PTSD people routinely only get a few hours sleep.